don't we get started here? Got some interesting stuff for you guys this morning. This could probably go about any direction.
Hi, Dr. Cockerell, I can take this one. So the first thing that really catches the eye is just like this really curvy looking s- creature of sorts that we see. Um and it looks like it's directly on top of maybe just like a bunch of dead tissue at the very bottom. But you can kind of see like those very yellow looking spines in this creature, and it looks like it's got you can see like lots of, I believe it's either chitin or skeletal muscle, um and it may be some dried blood in there. So the first thought was that this was some sort of a bug. And whenever we saw the yellow spines, the first thing I thought was, could this be like myiasis?
Yeah, okay, good. That's exactly what it is. And what kind of biopsy do you think this was?
I don't know if it was just s- yeah, yeah. I don't know if it was just like some sort of a punch. And then you're kind of seeing it going down to maybe sub-Q there.
Yeah, actually, probably they just kind of maybe teased it out or did some kind of
Okay.
an investigation procedure. It probably was, it doesn't look like there's really any skin here. It basically looks just like it's the whole organism.
Hmm.
This material is, so you thought this might have been fat here.
Yeah.
Yeah, this is actually some of the glandular material inside the organism here. So this is actually still within the bug itself. And you can see there's still some of this insect. I'm not an entomologist, so I wouldn't even try to describe exactly what this stuff is, but these are probably some type of digestive gland, or they may be producing some kind of a material. There might even be reproductive organs inside the thing. Here's another chitinous part of the exoskeleton here. And yeah, that is the way to identify, like you mentioned before, these little yellowish spines that kind of come off the side. Um, now, and these things, they basically burrow into the skin, right? So these things live inside your skin. The way these things the way this thing sort of infects you basically is the fly lands on you and bites, and then it kind of causes an itching sensation. They lay its eggs on your skin, and then you auto inoculate it into the area. And probably out of all the eggs that they sort of lay on your skin, maybe just one or two maybe actually end up in there, and the rest of them never make it. But it gets in and goes in that little divot, if you will, that the fly made when it bit you, causes an itching sensation and scratches, so you auto inoculate. So this thing lives down inside your dermis. Most of the time when we see these, we see it's sort of thought to be an abscess or a cyst or something like that. And we do get like an excisional biopsy or a punch biopsy of the entire process. Patients will often complain of the things kind of moving in their skin. And this is the way to really tell these things when you actually have the organism, this chitinous exoskeleton and these yellowish spines. They actually look black when you see this yellowish brown color. So they look yellowish histologically, but they're actually black when you see them in the actual organism itself. They have these little rings of it's white and these black rings around them, and those are those little spines. So, what other organisms do you have to like think about? I mean, you got this one right, but what else do you have to think about when you see one of these ectoparasites like this? So the board may put some things on there and expect you to be able to tell them apart.
I guess you might have to be able to know, I don't know if like necessarily like what kind of myiasis, but if there is something like a burrowing flea, or
Okay, good. Yeah, I think they would probably think you should be able to tell the difference between this and that. Now, what is that so-called burrowing flea? What's that diagnosis? I think they showed that on my boards years ago. So they do show that every now and then.
That's the tung. What's it? I think it starts with the T.
Yeah, it
Tungai.
starts with Tunga penetrans.
Hmm.
And basically, that usually occurs on the soles. People go down to Belize or whatever for spring break. They're walking around barefoot on the beach, and they get a beach that's infested with they call it sand flea, or jigo is the other name for it. And then usually somebody's got a small defect in their foot or something, and they're standing in an area, and then when the flea burrows inside of you, you have to stand for sort of a few minutes, I would think, for the thing to get in there. But I'm not sure anybody's looked at the exact how fast that the thing can get into your skin. So that'd be one thing that you'd think about. What else would they maybe expect you to be able to tell from this morphology that it was or was not?
Like if it was like cutaneous or migrans or like Myiasis or something like that.
Well, cutaneous larva migrans, that would get you that the only way you'd really be able to see that would be with a punch biopsy of the skin, because that's got a very, very small, tiny organism that's really hard to see. And it usually is migrating right around the level of the between the epidermis and the papillary dermis. And it's really tough to see histologically. Usually when you people biopsy that, they biopsy the burrow, that you see in the skin, the tunnel, and that is actually the inflammatory reaction. The organism is ahead of that. So the organism is moving along. It's almost like a vapor trail in an airplane. So when you biopsy that, you don't see the airplane anymore. You just see the vapor, the whatever it is, the carbon dioxide or whatever is up there. So when you biopsy the trail of cutaneous larva migrans, you see what looks almost like an insect bite reaction. It's urticarial eruption with the eosinophils. You have to biopsy ahead of that thing to actually get the organism. And most people usually don't biopsy that, so we almost never see it histologically. But that'd be so much smaller than this, it really wouldn't look anything like this. But there's a couple of other things that might look like this that they might ask you. So what if this were not inside the skin, but it was on the surface of the skin, and maybe it was attached to the skin? What could look, and it's in the same general family of organisms, if you will, rather than cutaneous larva migrans, which is a helminth. Um, what else could look sort of like this with an exoskeleton and be an ectoparasite also, that you should at least know what they look like in general?
Like a tick bite.
Tick. Yeah, and sometimes we actually get the tick itself submitted to us. Sometimes you get a biopsy. They think it's rule out melanoma because the tick is still attached and it's black, and so the clinician thinks it's melanoma. Obviously, this isn't a tick. You'll see the obvious, tick mouth parts. Usually, it's attached to the skin. So if they showed you something like that, they'd probably show it with maybe some tick mouth parts attached to it. So, probably the only other thing they might throw in there, they might put in something, say, like a louse, body louse or pubic louse, crab louse. Make sure you know what those look like. They look completely different than this. And if they were to show you something like this, they probably would show it to you when it was maybe in situ, or they might show a gross picture of it and then show this along with it, and then maybe ask you a question or two about it. What's the name of the human myiasis organism?
Dermatobia hominis.
Yeah, and that's the one that actually has a tropism for people. Okay, good. I'm going to take a look at this one.
Okay, I can do this one. So it looks like we have a shave here. Um, and the epidermis, so there's some orthokeratosis, maybe a little bit of acanthosis, and like the suprabasilar epidermis, like towards the top there, looks like there's like some holes up there. Um, so going in closer, there's like some degeneration of the superficial epidermal keratinocytes there, it looked like. Um, Otherwise, I didn't notice too much that was abnormal with this slide. Given these findings, I thought it was most consistent with epidermolytic hyperkeratosis.
Okay, good. That's the reaction pattern. Okay, and it's good, and you can see that if you look carefully inside the cytoplasm, it does have these little almost keratohyalin-like granules in there. That's very characteristic of it. It does have some thick cornified layer. It's kind of basket weave. Sometimes it sort of takes on kind of almost a purplish color like this a little bit. And so they might show you something like this and expect you to pretty quickly recognize the reaction pattern like you did. So what they might do then is ask you some questions, second order questions about where you might see this reaction pattern. So what are some conditions where you take a biopsy, you see this, and you have to come up with a final diagnosis? What are some clinical scenarios where you can see this reaction pattern?
I think the like the variant of the ichthyosis, the epidermolytic hyperkeratosis, or the ichthyosiform erythema could be one, and then
Yeah, that's
it
kind of a
also,
classic one that you think about, and that can be seen in the widespread form that we used to call it congenital bullous ichthyosiform erythroderma. I don't know if they still call it that anymore, but the bullous part was because of this. They would get erosive changes when the kids were born, and then later on, they get these markedly verrucous, thick hyperkeratotic areas. They get secondarily infected with bacteria and really develop some really, smelly kind of processes. So yeah, that's probably the number one. And what are some other scenarios where you could see this?
I think sometimes people can have like a solitary lesion that looks like this.
Yes, that's
Uh,
right.
I think you can also see it in like epidermal nevus as well.
Which is basically the same thing as the epidermolytic hyperkeratosis gene, germline mutation, but it occurs in a somatic post-zygotic mutation. So usually it occurs kind of like a systematized form. Looks like an epidermal nevus clinically. You biopsy it, and lo and behold, you see this. There's a
Yes.
couple other scenarios where you can see it. You're pretty close to the end, though.
I think maybe also the Warner PPK.
Yeah, I think you do see it in that on occasion. I don't know that that's the most common pattern, but I think you can see it there sometimes.
Maybe like an early friction blister as well.
Not usually epidermolytic hyperkeratosis with that. That's usually just kind of a very superficial up in here, little sort of shearing of the keratinocytes. But there's one or two other scenarios where you do see the histologic reaction pattern of epidermolytic hyperkeratosis that is not a genetic process.
I know like sometimes like if you get a biopsy, you can just see it incidentally, like
You can see it incidentally, but
mhm.
sometimes it can be seen in association with palmoplantar keratoderma that can be associated with underlying malignancy. I think that so-called tylosis palmaris et plantaris, sometimes that shows this finding also, interestingly enough. Um, I'm not sure it's exactly the same thing, but it, at least histologically, it's been described as being seen in that scenario. So that's something else you have to think about if it's a palmoplantar variant. So you just put that in there as well. Um, Now they might ask you on the exam, I don't know that they would do this, but they might say, what are some items in the differential diagnosis of this, rather than asking you what diseases are associated with this. So what if they put like a flat wart? Would you think this might be chorocytosis associated with a verruca?
I guess it could look like that.
A little bit like it, but it doesn't look exactly like it. You usually don't get those pink keratohyalin granule-like structures inside the keratinocytes, and generally it wouldn't be over a very broad front like this. The other thing they might throw in there might be, say, like a deficiency disease, like glucagonoma or necrolytic acral erythema or something along those lines. Would that possibly confuse you.
I think in those conditions, you would have paleness of the keratinocytes, but not necessarily just like degeneration like this.
Yeah, that's true. You get pallor and ballooning degeneration, and you get psoriasiform hyperplasia associated with that. So, yeah, but I kind of doubt that they would do something like that because especially like a flat wart, the corticolytic change can look pretty much like this. So I don't think they would ask you that. But anyway, that's good. You make sure you know these epidermal reaction patterns. This one, focal acantholytic disc keratosis, glycogenic acanthosis, obviously spongiosis, ballooning. Know all of those and know the diseases that they're associated with because they will ask you questions about that for sure.
Um, uh, I can take this one. So
Okay.
this look like a very deep shave or maybe an excision specimen.
Yes.
Um,
Incisional biopsy.
yeah, like an excision. So just starting from the top, I see some pseudo epidermolytic hyperplasia.
Okay.
I see a breaks inflammatory pattern in the superficial to mid image.
Okay.
When I zoomed in, I think it was mostly lymphocytes and histiocytes, so a lymphohistiocytic superficial to mid derma inflammatory pattern. Um, then I also saw some pigment that was black to me, like they look very black. They didn't look like something that is produced by the human bo- body. It wasn't like golden brown. I think it was more of like some black pigment. So I was thinking this is more like an exogenous pigment, like a tattoo reaction pattern. Or, or, or other things that can also give you like a black pigment, can be like a pencil, or if you have like if you have car, 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 carbon, or if you have like metal. Those are other like exogenous things that can give you a black pigment. But I think this was more consistent with like a tattoo reaction pattern.
Yeah, there's definitely foreign material in here. And it does look like you look really carefully, you see these little fine granules here. If it's carbon, it's generally just absolutely jet black. You
Okay.
can't see anything through it. This has got, you can see these little tiny particles. It's almost kind of reddish brown a little bit. Some of this actually looks red if you look really carefully. It's hard to see with this scan image. Um, so it's more likely to be some sort of, and here you can see some of it's kind of got a reddish tint to it. So you're right, it is a tattoo reaction. And again, I don't know that they're going to expect you necessarily to look at something like this and make the distinction between the type of tattoo material that this is, but they might ask on some other part of the exam what the pigment is in some of these tattoos. So here, let's say it's not carbon, let's say it is kind of reddish, for example. What what is the color in red tattoo pigment?
I know that red tattoo pigment can give you like an inflammatory response due to mercuric or cinnabar.
Good, cinnabar, which is a
Yeah.
mercury-containing pigment. So yeah, that's right. That is what the red color is, and it is probably one of the most antigenic of the types of pigments. What is say, for example, blue? What color is blue in the skin?
Hmm. Um, I know if the pigment is like deep, it can be due to like melanin if it's deep in the skin, like you see in blue never, like due
Yeah,
to the tandem
that
effect.
can impart a bluish gray color to the lesion. But if you look at the pigment in the dermis, obviously it's dark brown or looks almost black in some cases if it's really present in abundance. But if you wanted to, someone put a tattoo in their skin and they wanted the color to be blue, what's the pigment that they use for that?
I'm I'm not sure.
Okay, it's usually cobalt.
Cobalt.
Cobalt is blue, so cobalt blue, that's for the bluish pigment. And then what about if it's green?
Green, I'm not sure.
It's got kind of a copper color. So it's like a copper moiety for green. And what about yellow?
Green is copper. No, I don't know those other colors.
And that one's they call a cadmium is what they use for yellow. So sometimes they might ask you a question about some of the various chemicals that cause these pigments. Now let's say this material here was mostly brown, and it looks like it's kind of reddish brown. What kind of tattoos are generally used to produce kind of a brown color in the skin?
I don't know.
Well, the vegetable dyes. So in other words, these people that get the tattoos, the microblading of their eyebrows and lips and eyelids and that kind of thing. And this part actually probably is carbon here, by the way. So this is a jet black area. And these tattoos, they have multiple colors in them. They'll have red, green, yellow, black, blue, all sorts of colors of the rainbow in there. So it's not uncommon to see multiple different tattoo inks. But the vegetable dyes that they use for this microblading, those are really strikingly antigenic, even more than these supposedly inert dyes for these inks. And those can give you severe granulomatous reactions. And we've seen a number of cases over the years, especially of African-American women who get these procedures done and they have underlying sarcoidosis, or maybe they have a tendency to have sarcoidosis and they get this horrible sarcoidal granulomatous dermatitis that develops right at the sites of the vegetable tattoo that's been used. And we've even seen some cases where they didn't have any known sarcoid before, get this, and suddenly they pop up with mediastinal lymphadenopathy. It sort of triggers a systemic sarcoidosis in some of those patients. So just remember that. They could ask you a question about that because it is sort of a public health problem in a way. A lot of people get those tattoos done. That material is not regulated by the FDA, I don't think, all the time. And some of those things contain impurities, and they're far more allergenic than regular tattoo reactions. Now, this is kind of an interesting one because most of the time we see allergic reaction tattoos, we see more of a granulomatous infiltrate. Occasionally, you'll just get this fairly diffuse infiltrate with mostly lymphocytes and just a few histiocytes, and sometimes even overlying spongiosis. And you see the patients, they come in, it looks almost like an allergic contact dermatitis to the tattoo. And you biopsy and it shows this as opposed to showing the granulomatous reaction. The only other thing you need to worry about when you get these tattoos is was there some infectious agent introduced at the time of the tattoo? Did they put in AFB, for example, or some kind of another bacterium? So we'll often stain these to make sure there's no evidence of any underlying infectious agent in there. Good.
Thank you.
Hey.
I can take this one. Can you hear me?
Yes, absolutely.
Okay, so this looks like a shave, or deep shave. You see a little bit of fat at the bottom.
Possibly even.
Yeah,
Big piece of skin. We like these kind of biopsies.
yeah. Anyways, when I was going top to bottom. The epidermis largely looked pretty normal with some melanocytic nests. And then kind of on the peripheral side of the lesion looked like normal nevus. And then in the middle, we have these like foamy cells. So I thought this was a balloon cell nevus.
Okay. So, but what's the overall pattern of the nevus here?
I would say compound. I thought I saw some nesting in the epidermis.
There's a few nests at the dermatological junction. Yeah, I'll agree with that. But is this, you said just a nevus, this is obviously taken by an excision technique, a big nevus. Let's say we didn't look at this part right away, and we just saw this part over here. Is there anything special about this nevus in this side? you see patients that come into the clinic and they have a little dome-shaped papule and you shave it off and it's a compound nevus. Does it usually look like this?
No. It's
No, it
normally
doesn't.
more well nested.
Well, there's some nice nests here. That's fine. But what's going on down in the dermis here? And furthermore, what's the size of this lesion compared to your little clinical dome-shaped papule that you remove and put a little dry solid on it?
Much larger. So
Much
would you
larger?
think this is more like the balloon cell melanoma?
No. I think you're right. But so if you see a small nevus and you shave it off, just a common garden variety compound nevus, this lesion's like maybe here it's over a centimeter, and we haven't even gotten the whole thing because it goes to both sides. So what kind of nevi do you know that are much larger than a typical compound nevus and have these nest of cells that extend pretty deep into the reticular dermis, and they're present around adnexal structures, follicles, and blood vessels down here in the lower part of the dermis?
Just like
So this side here,
congenital nevus?
congenital nevus, yes. So when you see this pattern of these cells extending around adnexal structures deep in the dermis like this is even around eccrine units here, that's a congenital nevus most likely. So that's the pattern that we see in a congenital nevus very commonly. So do you think they got the whole thing off here?
Doesn't look like it.
No.
At least on the peripheral edges.
This might be like a pretty large congenital nevus. Maybe they're doing a serial excision of it.
I see.
Okay. And so they get this, and guess what? They see this interesting population here in the middle of it. So you said it's a balloon cell nevus, but is it really a balloon cell nevus completely?
I guess not.
No, it's a congenital nevus.
With balloon cell changes.
A separate clone of balloon cells in it. And you see that quite commonly in congenital nevi. You'll excise like a kid that's got one of these giant congenital nevi on the trunk, and you excise it. Maybe it's got a central nodule, and it's got a separate clone of more primitive appearing sort of neural crest-like cells in the middle of that thing, and it looks atypical. Everybody says, "Oh my gosh, this kid's getting a melanoma in the middle of his nevus," and they're not. They just get a separate clone of cells. And sometimes you get a separate clone of cells that have a balloon cell morphology like this. And it's just an interesting phenomenon that we see in congenital nevi on occasion. And so if you see this in the setting of an obvious congenital nevus like this, it's pretty straightforward. You say, well, this is a balloon cell nevus. Now, you get balloon cell malignant melanoma too, right? So on the board, what if they say balloon cell melanoma rising into congenital nevus? Are you going to possibly choose that as an option?
No, I didn't see any like lymphocytes or pagetoid cells or anything like that.
Okay. Well, if it's one of these funny clones that's developing into melanoma, you may not see the epidermal involvement, and you may not even see a lymphocytic infiltrate in it either, by the way. So you have to look for certain other findings. So if you're looking at just one area within a large sea of something else, like for example, a soft tissue tumor that's got one area that's funny in it, because your soft tissue neoplasms develop into cancer sometimes, you apply the criteria that you would look at if this was the whole thing. So is this relatively small? Yeah, it is. Is it pretty symmetrical? Yeah, it is. It's fairly well circumscribed. It's this little small round nodular aggregation in the middle of this sea of a congenital nevus. And they're looking at higher magnification, and we don't see any mitotic figures. We don't see any pleomorphism. We don't see any striking atypicality. So we say, well, based on all that, this strongly favors a balloon cell clone within a congenital nevus, as opposed to a balloon cell melanoma, where you would see some of those other features. Now, if you saw, one area over here where there's like a lot of mitoses and some atypical cells, well, then you might get concerned about it. But based on that, I think we can feel pretty comfortable that this is just a benign clone of different cells within a congenital nevus. And you can get a lot of different types of clones. Sometimes you'll see clones that look like a Spitz's nevus sitting in the middle of a congenital nevus. Sometimes you'll see these BAP1 mutated areas within a conjugal nevus, usually more in a Spitz nevus, but we do see that on occasion too. So it's just kind of an interesting example. There's 8 types of melanocytes in the body. So small round, larger round, pagetoid, balloon, oval, spindle, multinucleated, and dendritic. Those are the main types that Dr. Ackerman used to make us sort of recite like a mantra all the time. So this has got the balloon cell in it, but it's also got the other features of a conjugal nevus here. Any questions about that one? Okay, this is a good one here.
Okay, I'll take this one. Starting at the top, I saw some neutrophils in the stratum corneum, and the epidermis.
I think it really strikes your eye though when you look at this thing, the epidermis.
Oh no, I was just working
No.
top to bottom. The dermis definitely strikes. Is like the first thing that I noticed about the specimen.
Good. Yeah, I don't usually start at the top and work the bottom. I'm not sure who did that. I like looking at the entire thing. You know, it's like if you're looking at a piece of art, I don't just look at the person's hair and then move down to the nose and forehead and all this kind of stuff. I look at the entire Mona Lisa, and then let's appreciate the entire thing. So obviously there's epidermal changes here, but the action is here. This is where the action is. So you don't need to mess with the epidermis yet. We might look at it in a minute, but I like just looking at this. So what do you think we're dealing with here?
Like a nodular dermatitis, like a palisading pattern.
Okay, so you think it's, so you hopped into the inflammatory side of the equation.
Mm-hmm.
So it's inflammatory, nodular, and you think it's histiocytic, right? And so you think it's a palisading, so palisading granulomatous dermatitis. Okay, good. Yep. Let's go to higher magnification. So what's the diagnosis?
I was thinking it was NXG.
NXG, okay.
I didn't see that many cholesterol clefts, but I thought it was like degenerated collagen in the middle.
Okay. Is that the only situation where you get degenerated collagen?
No, you can also get it in necrobiosis, lipoidica.
Okay. Where else can you see it? What if we just had this piece right here?
You could also see it in lupus.
You can see it, not so much in lupus, but there is one palisaded granulomatous dermatitis where you can get degenerated collagen in the center of the palisade.
At GA?
No.
I know GA is like mostly mucin.
Yes. There's one other one. Well, NLD, sometimes you can see it in rheumatoid nodule too, but that's usually fibrin. But NLD is probably the one, I guess, would be the best one there. But we don't have that here, do we? What do we have in this situation? The other thing about necrobiotic xanthogranuloma, it's a very diffuse plaque-like process. If you've ever seen a patient with that, they get these big yellowish plaques, often around the eyes. They ulcerate. They get diffuse palisaded granulomatous dermatitis with lots of histiocytes that have lipid in the cytoplasm. They always have cholesterol clefts. So this thing looks fairly well circumscribed, doesn't it?
Yeah, it does.
This thing. And if you look at this piece over here, which is the same process just off to the side of it, so that's the center of it, this is the side of it, we've got a small, well-circumscribed area that's comprised of these angulated cells here with dilated blood vessels. So we just saw this piece. What would be your diagnosis?
The same or?
Well, it could be still the same, but let's see if we can figure something else out. Well, let's take a look at the side, the periphery of it. Okay. Do you see any thick keloidal collagen bundles here with these angulated cells that are spindle in shape and plump that are basically surrounding these cells? Does that kind of give you a clue?
Would it be like a DF?
Yeah, a dermatofibroma. A dermatofibroma. And you can get degenerated collagen in a dermatofibroma. I mean, this basically is just probably a large cellular DF that just underwent some collagen degeneration. But beware of using one feature, and this actually could have been maybe where they took a prior biopsy action. So maybe they took a biopsy of this thing. That's what maybe this was all about. They got back the diagnosis of a cellular dermatofibroma. They said, well, let's just go excise it. It's ugly. Patient doesn't like it. Let's just take it out. And maybe this is where they originally did a punch biopsy. That's another explanation for what we're seeing here. So don't just use one thing necessarily to sort of trump you and push you into the diagnosis of something that it really isn't. Because yeah, you get degenerated collagen, necrotic xanthogranuloma, but you see a lot more other things too. And you're right, there are no cholesterol cliffs, there are no foamy histiocytes. That condition is actually thought to be a manifestation of a paraproteinemia. The paraproteins precipitate in the skin, and that quasi-foamy material, a lot of those are due to the paraprotein that's in the skin. It's not necessarily like circulating lipid that gives you that material. Look at the epidermal change here. What do you see over here?
You see a tabling of the reedy ridges?
Well, yeah, you've got these basaloid proliferations. And you know that overlying a DF, you can get this pseudo-basaloid basal cell carcinoma-like change. It's basaloid proliferation can simulate basal cell carcinoma. Another explanation for this could be maybe they took a shaved biopsy, maybe they got this, maybe they got the diagnosis of basal cell, and they went back and re-excised it, and lo and behold, it wasn't a basal cell. It was a DF. I mean, we see that all the time, where the clinician takes a superficial shave, they just get the basal cell areas, gets called basal cell, and it's not a basal cell. Go back and re-excise it. So there's a whole bunch of different variants of dermatofibromas. This would be more kind of a cellular variant. But notice these cells, you see these kind of jagged, plump cells, dilated vessels, collagen bundles. That's really classic for a dermatofibroma. These are the fibrohistiocytic cells that are present in this dermatofibroma here. So this is a large one, and they can get to be pretty big, especially like when they're on the ankle, the so-called ankle type of DF, which can be, several centimeters in size sometimes. It can be really, really big. So this does have a lot of collagen degeneration in it, but just the lesson, I guess, is that you can see that in dermatofibromas also. It doesn't necessarily mean that it's some other entity. So don't just let one finding confuse you. Make sure you look at everything here. Don't just say, well, this is here, but all this other stuff isn't here. It still has to be the other condition. That can throw you off. And the boards love to do that. They'll put one obvious feature on there and they'll say, well, this will trick the people that aren't really, knowledgeable about this, the unwary types. So you don't want to fall into that pit. Okay, let's get this one.
Okay, I can do this one. So we have a punch. The action to me looks like it's in the upper dermis. It looks like there's a bunch of these purple squiggly lines in the upper dermis, which I thought represented clumped, calcified purple elastic fibers. So I was thinking that this one was Pseudoxanthoma Elasticum.
Yeah, and it's pretty pathognomonic. If you see this, and you should recognize this. That's good that you were able to recognize that. I'm sure you have plenty of time to study it. So that's good. And this is classic for that condition. So now there's several different settings where you can see Pseudoxanthoma elasticum. So this might be one of these where they expect you to recognize this so-called steel wool appearance here. They might expect you to recognize this right away, and they're going to maybe ask you some questions about it. So what kind of questions do you think they might ask you when you're going to prepare yourself?
They might ask like what the mutation is.
They might. You know what that is?
Yes, in the ABCC6 gene, which is like the transporter.
And what's the inheritance pattern?
Autosomal recessive.
And what's the clinical manifestations that these people usually get?
Usually yellowish papules in the flexural areas.
Good. Is there any other part of the body that you want to look at in
Um,
these patients?
yes, it can also affect the eyes. They can get angioid streaks.
Yeah, there are breaks in Brooks membrane. Now, I'm not an ophthalmologist, but that's kind of in the background of the retinal area. So they can get retinal detachments and things like that sometimes. And anywhere there's elastic fibers in the body, you can get some abnormalities there. You can get heart valve abnormalities with this thing also. Okay, good. Are there any drugs that cause this?
Penicillamine can look
Yes,
similar.
that's a classic one. Yeah. Is there anything different about the histology of the calcified elastic fibers in penicillamine versus the inherited type?
Mm, I don't know what it would be, but
The penicillamine type gives you the so-called bramble bush morphology. If you look really carefully, which we do not see here, so this probably is not the penicillamine, they get these little kind of tiny knobs that come off at right angles to the elastic fibers. And you can actually, if you do an elastic tissue stain, you can see that. Now, I don't know if they'll ask you that, but that's the classic differentiating feature between the penicillamine-induced PXE and the autosomal recessive variant of PXE. So just you can remember that. Are there any other settings where we see PXE-like changes, but they don't have PXE?
if they've been exposed to calcium salts,
I haven't heard that one. Is that true? I haven't
uh,
heard that.
I'm not
Maybe
sure.
it's right.
It was in Elston's textbook, so I'm not sure.
Well,
So
how do they get exposed to the calcium salts? They eat calcium carbonate like chalk or something,
I'm not sure. Yeah.
Well, actually, what happens is you can see a PXE-like reaction pattern sometimes in scars. And we'll see women that have had maybe multi-parous women, they'll get like stria, trophicans, maybe they had a C-section or something like that, and you biopsy those areas. And you can see localized areas of PXE-like change in there. They don't have PXE, but they get PXE-like changes of their elastic fibers sometimes in those areas. Sometimes you'll see necrobiosis lipoidica, the degenerated collagen, sclerotic collagen. You'll see small foci of PXE-like changes in there also, and that just can be just kind of a coincidental finding. So it doesn't mean they have PXE. It means that just occasionally they get PXE-like findings in there. So that's good. So you're prepared for this. Good. They very well might show you this on the exam. So glad you know the genes, glad you know the histology. Now you know the difference between the penicillamine versus the non-penicillamine type. Beautiful example of this.
I can take this one. Can you hear me okay?
Absolutely.
Okay, good. I will get off my phone. I was on both. Okay, so we have an excision, and then in the superficial dermis, there's this horizontal kind of plate-like growth, primarily composed of these like lighter epithelioid cells, but also these more like clear cells that have some like vacuolization. And then kind of looking closer, can also see some a little bit of palisading around the growth.
Good.
I thought this was good for a tumor of follicular infundibulum.
Yeah, this is just as good as it gets. I mean, we usually only get, punch shave biopsies of things, and I'm not sure why this is here, to be honest with you. I don't know if they had a diagnosis of this and they just went back and re-excised it. Maybe they weren't sure if it was benign or malignant. They decided to cut it out. I don't know if they
Yeah.
maybe had another lesion of a basal cell somewhere else,
Right, that's what I was thinking.
or maybe a misdiagnosis. Maybe it was called a basal cell. We see a lot of these that get shaved and they get called that, but I don't really see any scar or anything here. So it may just be kind of lesion. Okay, good. That's exactly what this is. So this is with these hair follicle tumors, these adnexal tumors. It's really one of these things where you just kind of have to look at one, see one, know it in your brain, and be prepared to just answer the question when they put it on the exam. So they might throw in their differential diagnosis. They might put trichoepithelioma, might put something like fibrofolliculoma, Birdhog-Dubé, things of that nature. But the horizontal nature of this thing is really classic. And this thing really, if you look at it, it's got multiple areas. It's probably not the world's best name because it really doesn't look like the infundibulum of the follicle. It actually is a neoplasm that's really differentiating from the mantle zone. It's really more like a mantleoma. So these are these little primitive structures that basically the residual stem cells that live right in the isthmus of the mantle zone that basically form this neoplasm that's got this little follicular structure here with a little infundibulum there. It's even got a couple of sebaceous cells in here. It's got some tricholimal differentiation, like you pointed out. So it's pretty straightforward. And just make sure you know the differential diagnosis and that this is obvious when it's this horizontal plate-like morphology here. Okay, it's pretty so easy. There's really hard to think of ways to please you about it. Okay,
Awesome. Thank you.
Next one.
I can do this one. This looked like an excision, a pretty large excision of, I couldn't really tell what the excision was of. You can see like young scars, like the collagen and histiocytes running parallel to the epidermis. And you can see some lymphocytes probably going after whatever they were trying to cut out. In the center of the excision, it looks kind of fried, like pretty clumped up necrotic collagen. There's kind of some like electrocautery artifact with the nuclei elongated and kind of like that purple necrosis.
Yeah. Okay, good. That's really what we wanted to demonstrate here is the electrocautery artifact. Okay, you see that? So how does this happen? What's going on here?
The person who excised this just used like the cautery to either stop some hemorrhaging or if they used it to cut it out.
Yeah, basically what's happening here is that it's almost like an in vivo electrophoresis in a way. The electricity gets applied to the skin and, your cells contain ions within them. And so it's, you have positive, negative ions. So they just basically get attracted to the electricity and they get elongated flowing towards the electric current, if you will. So yeah, I think they do show this occasionally on the board examination. I don't think they showed this on my exam, but I know they did show it a number of years ago and just expected you to be able to recognize. And they asked, because they want you to recognize some of these artifacts. So this polarization of these nuclei here, it's classic. What else might they try to confuse you with? It's an artifact that we see in the epidermis. What's another artifact that we see commonly?
Like freezing artifact?
Freeze artifact, good. What does that look like compared to this?
I feel like I usually see like it's like more streaky. Like I feel like it's from the processing after the fact.
But what if it, we actually, interestingly enough, get biopsies from, when we had that snowmageddon a few years ago, and we get a few biopsies that come in from the frozen north. We have a lady that sends us stuff from Wisconsin, and she sends it when it's like 10 below or 20 below. And it's not the processing, the tissue processing is perfectly fine. But basically, it gets so cold that the formaldehyde almost freezes, and you get that freeze artifact inside the cells. And that looks more like little holes in the epidermis, usually down here, sometimes a little bit above the epidermis, but usually in the basal cell layer just above it. And it can simulate melanoma in situ sometimes. And that we also see that when you look at frozen sections for Mohs. So when guys are doing Mohs surgery for melanoma in situ, for example, they often get that freeze artifact and it kind of simulate melanoma in situ sometimes because you get these holes down here, but you don't get this polarization of the nuclei in Freeze artifact. It's mostly just holes there. It looks a little different. So they wouldn't show that. Occasionally you will get somebody that's put an acid or chemical or something like that on their skin. What does that usually give you?
Sorry, can you repeat the question?
Let's say somebody applies hydrochloric acid to their skin, or they get an acid spill to their skin, or maybe they're doing something to themselves. What does that look like when you look at the epidermis?
I feel like you could probably have like full thickness epidermal necrosis, maybe a
Yeah,
blister.
good. You get like coagulation necrosis of the epidermal, of the keratinocytes. It looks different. Everything looks pink and dead. Good. That's a good point. Sometimes you get some change in the cornified layer. Um, what about silver nitrate? When somebody sticks silver nitrate, they get a silver nitrate tattoo on their skin. What does that look like?
Is it colored? Like you can see some pigment? Oh, I'm
Yeah,
thinking of
it's a black
camouflage.
silver pigment. It forms like almost like a looks almost like an eschar. It's not really an eschar, but it forms a jet black, almost wafer-like deposit of the silver nitrate in the cornified layer, and doesn't usually affect the epidermis. And that's often used for a styptic and that sort of thing to stop bleeding. Sometimes I don't think people are using that much anymore. But those are what some artifacts that you might see that they might show you. So make sure you know what those look like. This is a good example of this. I'm glad you're able to pick up this electrocautery artifact. If somebody gets struck by lightning, interestingly enough, they'll get that same kind of change in their epidermis, because it does the same thing. It kind of polarizes it towards the lightning bolt.
Okay, I can do this one. So we have a shave here, and from this low power, it seems like they're wanting us to focus like on a process in the dermis. We
Who's
see
they?
whoever biopsied it. Hopefully
Good. Yeah. Yeah. Right. Okay. What do you think their clinical differential diagnosis was?
Yeah, well, it was probably like a little nodule.
Yeah. Yes. Yes. It was a nodule.
Uh,
What color do you think it was?
it was probably like a little bit yellow skin colory.
Yeah, good.
Yeah.
Probably kind of a skin color, maybe a translucent papular nodule. Good. Can you
Uh,
tell what part of the body it's on?
um, it's kind of, I mean, on the epidermis, it looks kind of like there's some hyperkeratosis, but
It might be near acral skin. There's um, not a lot of hair follicles here, so it's probably not the face, probably not the scalp, anything like that. And got a lot of sun damage over here, so it's probably been a sun exposed area.
Mhm.
Okay. So yeah, some kind of, they thought it was a neoplasm,
Yeah.
translucent plasm. What do you think their number one differential diagnosis was?
Um, I don't know. Maybe they thought it was just like I guess if you saw a translucent kind of nodule in the skin, you could think like on the acral skin, you might think it's like a cyst of some sort, if you weren't sure. But I
Might, but what's if let's say some sun damaged skin here also, and it's kind of translucent, looks kind of pearly, what might they think about?
They might think it's the colloid milium if it's on sun damaged skin and it's kind of a
What about basal cell?
yeah, it could be a basal cell.
Hey, we thought this was a basal cell. Yeah, so they did a shave biopsy, and yes, they did want us to focus on the dermis, and we did. Is it a basal cell?
No.
No, it's not. What is it?
It looks like I thought this was kind of looking like nodular amyloid.
Okay. Why? Why nodular amyloid?
Well, it has this amorphous pink material with fissuring in the dermis. I mean, on my differential, I thought colloid milium, which would be good with like the solar elastosis. Because
Okay. So you're right. That's the differential diagnosis. How do you tell colloid milium from this?
I thought that colloid milium is a little bit higher up in the dermis.
It usually is up here, but it can kind of go deeper too. But yes, you're right. It usually goes all the way kind of up to the junction most of the time. But Not the number one way that you tell it from amyloid.
I know that amyloid has plasma cells kind of surrounding it.
Do you see that? That's helpful. There might be a couple over here. But what's the color of colloid versus the color of amyloid?
I thought they were both the pink kind of. I guess amyloid's more like.
Colloid's more kind of bluish gray,
Okay.
kind of purplish. It's basically colloid is just horrible solar elastosis that just turns into like bluish gray jello. It almost looks a little bit like hyaluronic acid injected, like Juvederm, that sort of thing. It looks a little bit like that, but not exactly. So go back and look at a picture of colloid milium, and you'll tell it looks quite a bit different. So yeah, amyloid looks like this light bubblegum pink color with these fractures like you described. And the nodular amyloid gives you this big, thick nodular aggregation, and they usually do look like non-melanoma skin cancer. Very commonly get sent in to us as rule out basal cell or something like that, because they do look kind of translucent like that, and clinicians aren't expecting it, especially if it's one or two nodules. They've been taught the macular amyloid and also the pink, the bruising around the eyes, that kind of thing. If somebody's got multiple myeloma. If you had this patient here, would you work them up for myeloma?
Probably not. Sorry?
Yeah, plasma cells, like you said.
Yeah.
I think you might want to make sure they didn't have something. Just to be on the safe side. Most of the time they don't. If it's just a solid lesion or something like this, it's usually not, but they can have it. And so it's probably not a bad idea just to make 100% sure if somebody's got nodular amyloidosis that they don't have an underlying, problem with plasma cell dyscrasia of some type or another. So it's not a bad idea, especially if they have plasma cells in the infiltrate. You could even possibly order kappa and lambda light chain, see if there's any light chain restriction here since you got plasma cells in the infiltrate. Now, the only other thing that sometimes comes up is lipoid proteinosis. Does that look like this?
That has more vertical, like the material was vertical.
It's like rocket ships, obviously around the eyes, the lips and those areas. Rocket ship, and the color of the material is really more hot pink, and it's homogeneous, and they usually don't get these clefts in it.
Mm-hmm.
If it looks fractured, bubblegum pink, nodular like this, nodular amyloidosis. Colloid milium looks more bluish gray, because it's basically kind of like horrible solar elastosis. And then the rocket ship pink of lipoid proteinosis. There's a few other deposits that you probably should know, like injections of collagen. That looks different. It's pink. It looks like more of a hot pink. It's in the dermis, esophagus, granulomas, inflammation surrounding it. So know your deposits, because they will ask about those too. And know that if you see plasma cells like this in nodular amyloidosis, you should at least think about the possibility of an underlying plasma cell dyscrasia.
Thank you.
Very good. Anybody want to do the last one in 1 second?
Oh my goodness, I don't know how well I can do that, but this is a shape biopsy of a papular-like lesion. I favored a neoplastic etiology. There's tons of these large cells. They have large nuclei. They're unlike each other, very irregular. There's tons of pigment. And it's kind of like these cells are going into the epidermis. There's some like buckshot scatter. And then if we look at the adnexal structures, those cells are there too. So I was wondering whether this could be like a nodular melanoma.
Good. And if they show you melanoma on the exam, this is the kind of one you're going to get. So this is almost kind of like a dangerous doctor question. Make sure that every single one of you got this right. So this is an easy one. It's an obvious malignant melanoma. You're exactly right. Everything you described a minute ago is precisely what you would see. They probably aren't going to get in and ask you the differential diagnosis between nodular and melanoma, linear-malignant melanoma and all that sort of stuff, but they would definitely expect you to diagnose this as malignant melanoma. Very good. So make sure you know that backwards and forwards. So we'll see you guys next time.